But yeah, I want to start out. I'm wearing two hats. My first hat will be kind of lay out the vision of the conference, and then present my piece. The the national debate and a lot of research policy effort around healthcare. Tom and I at least think that it's disproportionately about who pays, getting those insurance cards in people's pockets. And in the process may have undermined the availability of healthcare now and in the future. And that's why we wanted to have a supply side health economics conference. And we wouldn't be able to do this without a lot of help. If you've met Sri, she's organized this in an amazing way. I saw from the econ department, Madison was here, and Jessica I saw earlier came over to help. The Harris School made a contribution to this conference. We appreciate that. The booth, the healthcare initiative over at booth, and also their applied AI group made a contribution. And we have our research team here taking time off of coding, which is fun stuff, right? But off to help also to participate, and we're hope to hear their insights as well. So maybe I put it a little too bluntly, but this obsession about who pays, I think of that as an instance of the classic error of utopianism. That not only does it just assume great numbers of chickens, if you heard that Soviet saying, assumes great numbers of chickens, but also that the chickens can and will fly directly into people's mouths, already feathered and cooked. No, healthcare has to come from somewhere. It needs to be supplied. Who supplies healthcare is quite critical. And so today's program is organized around some of the most important elements of healthcare supply. One of those would be the manufacturing of drugs and devices. And we have a talk today by Allison about weight loss drugs. Moise is here. He was going to talk about policies related to the supply of healthcare workers. Very important. And we shouldn't forget the patient. The patient's not legally an employee, but they're maybe the most important laborer in the healthcare process. And we may be on the cusp of innovations that have the potential to help patients be more productive. And those are especially artificial intelligence tools that can help the patient have more medical knowledge and make better medical decisions when they're at home, when they're with their family. But we also expect, of course, companies to use the new AI technologies too. So we're going to have both of those perspectives come up today. Tom will give a talk on AI, especially on the company side, and also Joe Grogan, who's going to join us virtually. Now, did anybody miss the or notice the misspelling in the artwork? Giuseppe noticed. Good. That's a metaphor for messing up the little things that can undermine an entire enterprise. A big problem, not the only, but a big problem with a centrally planned system, or a system that prohibits profit. It removes the incentives to make the necessary but mundane contributions to supply. And things like getting the spelling right is quite a mundane thing. It's not glorious. It's not something a politician wants to pursue. But we need those mundane things. And that kind of leads to my contribution to the conference, which is to talk about the boring business innovation. I hope my talk's not boring, but business is much less exciting than discovering new chemicals and things like that. So let me turn to the presentation on business innovation. And one of my main examples you might have seen on the program refers to buyers clubs. One of my main examples is of business innovation is buyers clubs. Yeah, that was right. There we go. Yep, that's the one. Okay. One of the challenges for humanity is funding intellectual property and making it available. Of course, we know, we've seen this in economics a lot, creating intellectual property is a fixed cost, meaning it doesn't matter how many people use that knowledge, the cost doesn't really vary with that. It's obtaining the knowledge that creates the fixed cost. So who's going to pay that fixed cost? One idea, it's very common in economic models. I actually don't think that common in the marketplace, that each consumer pays in proportion to the amount used. And a problem with that is it leads to underutilization. The people, when they purchase a product, a new product, they're not only paying for the cost of making that instance of the product, but they're also having to pay for the intellectual property. And so they purchase too little. Another strategy in economics known as two-part pricing would be have some kind of membership fees that are not so tied to utilization that finance the fixed costs, and then people pay the marginal cost to the extent there is one on those new products. And then a third strategy is Ramsey pricing, a multi-product firm. And the idea there is, well, if we're going to have to recover that fixed cost by charging people in proportion to what they buy, maybe we can recover it on the goods that where the underutilization won't be such a drastic problem. And that's called Ramsey pricing. And we see that very much in healthcare. Again, gets ignored so much that the health insurance company is delivering many products. One company, many products. Pharmacy benefit manager, which I talk about today, they are dealing with many different drugs, and they can recover the fixed costs for drug B through their charges on drug A, if that might lead to less underutilization. And this gets forgotten a lot. And it's funny because when we talk about underutilization, one of the classic things in economics, not just health economics, is insulin. Well, the demand for insulin is not very price elastic. Great place to recover fixed costs. And we see the market doing that sometimes, and that's made a lot of press. But the economic analysis hasn't quite reflected that, wait a second, we got to recover the fixed cost somewhere. Maybe insulin's not such a bad place to do it. Figure out how to do these things. It's not easy. We're not born with that knowledge. It needs to be discovered, and that's the role for entrepreneurship. One of the challenges for entrepreneurs, if you're going to do a two-part pricing scheme, for example, how are you going to prevent members from reselling to non-members? If your scheme is have a membership fee, and then you can buy these healthcare products very cheaply at the margin, maybe I should buy not this enough for me, but for other non-members and resell it to them. So you have to deal with that. Now you might say, well, that sounds kind of strange, but remember, an individual can be a member at some times and a non-member at other times. So they can do that with themselves, so to speak. There's the question, who are the members going to be? And I'm not referring to the Groucho Marx joke about being members in clubs, but there's the question of who, if we're going to recover the fixed costs and try to have the fewest economic distortions, what's the right group to bring together? And then in the multi-product approach to things, which products are going to be sold together? And there are companies doing all these things at the same time in different combinations that are constantly discovering better ways to do it. Okay, I'm going to refer to a concept from microeconomics called the core. Really, the background for why we want to think about the core is we do so much in groups. We're a group here today, right? It's even rare for people to live alone. Now, somebody might say, wait, I have my own apartment. Well, but you're in a building and you're sharing snow shoveling, maybe a gym, parking. So it's rare even to live alone. We're doing things in groups. And I think when without getting into some ideas of the core, we're missing out on that fact. We're modeling individuals. That's not how we live. We don't live as individuals. We live in groups. And you think about, I think we had roughly 50 people engaged in the conference right now between online and in person. How many ways could we arrange? Just 50 people. I'm not talking about all 300 million people in America. How many ways could we arrange us in groups when we're in the break time? Some of us will talk in pairs and threes, fours. How many ways can you do that? Anybody know? It's literally an astronomical number. It is a bigger number than the amount of centimeters from here to Pluto. When I was a kid, we called it the planet Pluto. I guess it's not a planet anymore, but it's still there. And it's a lot of centimeters away. But the number of ways we could arrange the conference participants exceeds that. There's no way a bureaucrat can even begin to list the possible ways that we could organize together, let alone assess which ones are the best. And this is why a very important part of supply would be the market, that we have people organically forming groups, joining groups, quitting groups, joining other groups. This is incredibly important. We see it happening. So the definition of the core is if it's allocating the resources in the economy in a way that can't be improved by any coalition, which means taking a group of people and say, we're going to quit our existing groups and form a new group. And there's the, that's the formula I use to show that it's more than the number of centimeters to Pluto, 2 to the n being 50 minus 2 possible ways to do it. And these coalitions are organized with voluntary membership. This is extremely important. The voluntary part, that's how you're going to make improvements, because there's, which one of these 2 to the n minus 2 are we going to pick? We have to let people try new things, join new groups. One of the reasons why I find health insurance mandates to be problematic, because they are forcing people to be in a group rather than having it a subject of choice, which is really the engine of progress. So let me give an example now of a particular type of group. I already alluded, there are lots of groups, families, people who live in an apartment building together. But one of these groups that looms rather large in the supply of healthcare would be buyers clubs. You might think of Costco as a buyers club. They actually are involved in healthcare, but they're a buyers club for skateboards and lawn chairs, tents even. But they form a group to negotiate with the manufacturer. And these groups can be a small set of consumers. You don't want to be confused to think that, well, the way a buyer's club work is it's really massive. And it really puts pressure. You know, you can put pressure on the manufacturer just with a small group of consumers. An example of that I'm sure you've run into, maybe you hadn't noticed, would be this sale of soda. Whoops, I spelled soda wrong here. S-O-D-A. The reason I spelled it wrong because in Illinois we call it pop. I never even use that word, but if you go to the restaurant, very many restaurants only offer Coke or only offer Pepsi, right? You've seen that. Oh, may I have a Coke? Is Pepsi okay? Well, why are they doing that? Are they trying to make the Coke people upset? No, what they found is if they tell Coke and they tell Pepsi, look, I'm only going to carry yours if you give me an awesome deal. And that deal is passed on to the consumer. Even small restaurants do that. That's my point. The restaurant across the street from my house, they only offer Pepsi. This is a small restaurant. I mean, the lady owns 2 restaurants. She's not like McDonald's. She's not 1/1000th of McDonald's. She doesn't have the massive power of size, but she has the power to say, look, you can have none of the people in my restaurant or you can have them all. Give me a deal. And that's really the essence of the buyers clubs. And this is happens in healthcare a lot. Insurance plans are an example. They serve various functions, such as the financing, but they also serve the function of negotiating. They'll negotiate with the hospital, and they'll say, look, you can have all the people in my plan or none of them. Now, it's not quite that extreme. They'll put it in different tiers. Again, that's part of the innovation process. But even a small insurance plan can get a good deal from a hospital by giving them that all or nothing option. And then people want to join these plans, just like I want to go to the restaurant across my house. I don't like Pepsi. I don't know what we have here today. I prefer Coke, but I still go to that restaurant because what they've been able to assemble is not exactly tailored to what I want, but it's still better being part of the group. A particular, I mentioned one example, health insurance is a buyer's club. Now I want to talk about drug insurance, a particular type of insurance that's covering pharmaceutical prescriptions. And the idea that was discovered in my lifetime, not so long ago, was that, you know, if we're going to have insurance, maybe we want to manage it. We don't just want, even though the textbooks still model it this way, we don't just want to tell the consumer, look, here's your copay, here's your premium, come and purchase your pharmaceuticals if you so choose. It was decided that, you know, we should manage this a bit. We should manage what people are purchasing and how much, and we can use that to make the premiums cheaper or to make people healthier or some of both. And it'll turn out, I will show you how this particular type of buyers club has begun to solve the problem of paying for the fixed cost. The very thing that I started with today about, well, how are we going to cover fixed costs? Buyers clubs can do an element of that. It may be a little surprising because we think of these buyers clubs as trying to squeeze the manufacturer, and they are, but they also end up recovering substantial fixed cost. I had a piece, I'm not going to go through that piece today, but where I tried to look in the various aspects of buyers clubs for pharmaceuticals, and the buyers club process was worth 145 billion a year in the United States, net value added, over and above the value of having the drugs. Of course, the drugs, new innovative drugs are nice too, valuable. They induce the suppliers to compete more vigorously with each other. And plans end up getting better utilization at a lower price. And this is kind of this middle part is the trick for recovering the fixed costs. Getting better utilization, more people using the new therapy can help recover fixed costs, because the more of us that share the fixed costs, the cheaper it is for any individual. Okay, so here's I would say a supply and demand picture. It's mostly a demand picture of how the buyers club can work. So on the axis, I've drawn in the usual economics way, quantity on the horizontal axis, price on the vertical axis. Since we're talking about prescriptions here, number of dispenses, I'm going to express it on per member of the plan, and the dollar per prescription. I've drawn in here an isoprofit curve that will allow the maker of the drug to recover the fixed costs. They could recover the fixed costs if they sell to a few people at a high price or a lot of people at a low price. In some sense, the manufacturer doesn't care. What they want is a profit. They want to be able to recover enough profit to recover their investments. And in equilibrium, they'll, of course, anticipate this process. So they're only going to make the types of investments that they can recover somehow. Now, if they had an unmanaged benefit, meaning that quantity and price were just determined by the demand curve, there's a price, and then the patients just choose on their own, we might end up at a place like this. But the idea of buyers club is to say, can we improve on that for our members? Non-members won't participate in this, but our members will. And we can see lots of points that improve on that. Say that point at the red dot. That red dot also recovers the fixed costs. But it has more utilization and has Q1 rather than Q0. What is that worth? Well, we can measure it geometrically as the area under the demand curve and above the marginal cost between those two quantities. So that's when I said there's 145 billion, a significant chunk of that comes from moving that quantity out. It's moving it off the demand curve, and this is creating. This is one of the challenges of running it. So we have two prices here. We have the net price that's being paid. You know how much the manufacturer is receiving per unit quantity, but the club has people consuming at Q1, so they're presenting the members in effect with a price that's lower, the lower marginal price. Now we get into the problem here, the challenge with a buyer's clubs. How are you going to stop the members from buying at this low price and selling it to people at the higher price? Remember years ago, Tom and I talked about this around government programs. And we thought, well, people would laugh at us when we say that. Then we had the opioid epidemic where people were doing exactly that. Buying at a low price, actually a government subsidized price, and selling to others in their neighborhood. People died from that. But even
it's illegal with prescription medicine, but people can do it.
It happened millions of times.
It's illegal, but it's feasible.
I know that. It's not just feasible, it happens. And this can be and less, it wouldn't be illegal, for example, if I was on the plan for a year, I stored up my pills and then I went off the plan. And then I used my pills that I stored up. That's the same arbitrage. When I'm on the plan, I'm buying at this. And when I'm off the plan, as a non-member, I'd have to buy at that higher price. And if I've been able to do that. So that's one of the challenges with managing the benefit. How are you going to have two prices and without having any counterproductive behavior going on? So I draw an additional cost in here. There's a marginal cost, not just for making the drug, not just the manufacturer costs and the normal distribution costs, but you have to run this operation. It's going to take people. Sometimes they may have doctors that work for the insurance company who kind of look at the patient situation. Are they taking the right amount? Are they taking the right prescription? That costs. That's a cost. There's also opportunity cost. There's some of the people like me who's getting the Pepsi when he wants the Coke because the plan may be carrying one of these drugs and not the other, and the other drug might be a little bit better for them. And you hear a lot of these complaints in the press, and that's a cost. I count that as a cost. But there's an offsetting benefit that helps us as a club do better. So the way I get to an equilibrium here is, well, we move down that recover the fixed cost curve to the point where the marginal cost equals the marginal benefit. And that's why the equilibrium is not Q1, it's Q1 rather than some larger quantity and rather than some smaller quantity. And one of the things that's happened over time is that companies have discovered better and better ways to do this. As they've gained experience, technological change, maybe they'll be using AI as well. I haven't heard that directly. So these red dots have marched out to the right. Oh, before I march them out to the right, I should note there's a term of art in the industry called the rebate. The rebate is the gap between what the non-members pay and what the members pay on average. And we're going to track that as well. So as this industry has progressed, the red dot moves out to the right. More utilization, more surplus, also a bigger rebate. And this is one thing we've seen over time in this industry. The rebates have gotten bigger and bigger and bigger. That's a sign of progress. Or maybe I'll put it another way. If there were progress, that would occur. So there's one step, maybe another step. you see the red line is rotating. That's meaning they're figuring out cheaper ways to achieve these objectives. And therefore they can pursue the objective more. Okay. There are 4 prices in this market, and this is what creates some of the challenges that I've alluded to. There's the list price, the non-member price. There's the net price, which I showed. I'm going to call that P, total expenditure divided by the quantity. There's the marginal price, which is even lower. And then there's the marginal cost, not counting the marginal cost of running the buyer's club. So we have 4 prices lined up in order. Here they are in the picture. I put a red box around each price. There's 4 prices going on. I point that out because when we're studying these markets, we need to understand there's more than one price. This is why you need graduate school. An undergrad, supply and demand only has one price, right? You got to have graduate school where we can handle 4 prices. And anytime we're measuring prices in markets where they're doing this kind of volume discounting, we need to understand, which price am I measuring? Is it the marginal price? Is it the non-member price? Is it the average, the net price, the marginal cost? These are all different. And the theory has a lot to say about how they relate to each other. Give an example. It's called, again, this is a pejorative term. It's called the rebate trap. And what they're referring to is that the volume moving out to the right here is implemented by a rebate that is tied to the quantity purchased. So what the manufacturers and the plans agree to, they say, hey, plan, the more you purchase, the bigger rebate you'll get. The bigger that gap will be. And that's just moving down that blue curve. So to do a little arithmetic here, what's paid in total is on the left, the net price times the quantity. And the net price is the non-member price, the list price, times 1 minus the rebate rate. And the rebate's the percentage discount you get off the non-member price. And that's a function of the quantity. So what's the marginal price here? We know how to do this. Undergrads know how to do this. Some high school kids can do this. It's a first derivative with respect to the quantity. So that's what I've done here. And that's the marginal price that I showed in the previous diagram. And it has 2 terms. The first is the net price. That's part of the marginal price, but actually it's a discount at the margin. And it has to do with the fact that when I buy more, I get to save more on the drugs that I already purchased, that I was purchasing even at the lower quantity. And that's why in the picture, the marginal price was the 3rd lowest of the 3. Non-member price, net price, and then below that, the marginal price. And this is called, in the industry, by people who don't like the system, they call that a trap. Because they say, wow, plans are purchasing these drugs rather than generics because their marginal price is so low. Yeah, that's the whole point of making is to make the marginal price low. Okay, so we covered that. Now, how can drug innovation be rewarded with this? The innovators are the manufacturers, or even upstream from the manufacturers. So you would think, well, if the manufacturer has this buyer's club that's kind of squeezing them, how can they make enough money to innovate? Well, let's look at the different phases of drug development. And my horizontal axis here is time from the patent. So there's some initial time, unfortunately, where there's no cash flow to the manufacturer because they got their patent, but they haven't been approved by the regulators to have their drug in the market. So you have that phase. And then finally they get approval. And now they start to get cash flow. And at first, in the early phase, the cash flow is pretty good because they invented this new drug and the other companies haven't come up with theirs yet. Buyers Club has a little trouble squeezing such people because there's not a Coke and Pepsi choice. There's just a Pepsi choice or just a Coke choice. And so the main thing that happens in my picture, my demand picture, is we're moving to the right, but we're not moving down a whole lot. We're moving down some because the consumers need to be given a reason to expand their utilization. So utilization is expanded in this phase. And the manufacturers love this. I can tell you this firsthand. I've been to a conference where a pharmacy benefit managers, and there was all these manufacturers. I'm like, what are you guys doing here? Oh, we got a new drug coming out, and we want to make sure that on day one that the FDA puts the thumbs up, that we have lots of patients getting our new drug. And the PBMs are the key to that. And then there's a later phase. Once Coke is there, enjoying being the only one, and then Pepsi comes along. Now the buyers clubs, the buyers clubs are moving to the right, but now they're really moving down. Manufacturers hate that part. So you can see in the later phase, there's a loss to the manufacturers. And what I've done is try to see, well, which one dominates in present value? And it turns out the first one dominates in present value, in part because the first one comes earlier in the investment project. And then there's a generic phase, which I'm not going to get into generics today.
It's the trade-off that you get a bigger market quicker with the PBM.
Yeah.
And then you get nailed on the prices. Right?
Yep. Well, I mean, it's a trade-off in the macro sense. I mean, there's a 5 up there. Okay, this is working good. Yes.
And there's no other way of ensuring a quick market than buyers club.
Like I said, they were at the conference voluntarily and happily. I mean, they could send out their own salesmen and try to ramp things up. And that instead of this curve starting out high, it would start out low and start to build. And then next thing you know, Pepsi's there. I mean, you don't want that. You don't hear this, I know, because the manufacturers don't want you to hear it, but that's how it works. Okay, let me give it another example of fixed cost. One that we can remember because we had an infectious disease going around a couple of years ago. There are always ones going around, but ones that we really noticed went around a couple of years ago. It was kind of like the flu, more severe than the flu, but it had many features of the flu. So I want to start out talking about the flu using pre-COVID data. And I was wondering, where do people get the flu shot? It turns out a lot of employers offer the flu shot, including our own. You've probably gotten the emails on the days and times when you can get the UChicago flu shot. Among people who are employed, naturally, people who don't work for the University of Chicago don't come to Chicago for the flu shot, although we do have a hospital, they may do that. This is a very common place to receive the shot. If you look at which businesses and which employees were getting the shot at work, the smaller businesses weren't even offering it. Because naturally, this is again a scale economy kind of issue. We have a fixed cost. We're gonna have, they call it an occupational nurse who's trained to give people the jab, and he or she needs to be paid. And we can spread that cost among a lot of employees in a big company, and so big companies do it. Another example would be sick leave. Can we have a formal program to encourage people who have an infectious disease to stay home? And it's very common to have sick leave, again, at the bigger businesses. Okay. So what I did in a study relating to COVID, I looked at, well, how's it going on preventing the spread of COVID at work? Now, the pure medical people who don't do economics, they said, oh, big groups are bad for spreading disease. stay home. But they weren't thinking about the economic sides, like big groups are good because we can spread fixed costs over more people. We also have greater demand. When I'm in a big group, maybe it doesn't affect me wanting to prevent, but I would really like all my coworkers to prevent. So I did some study. I looked at the Duke Health System, where I could look both before they put in prevention measures and after, and they were open all the time. So, and we see before they put in prevention measures, a lot of spread happening in the Duke Health System among the employees. After about 2 weeks, they put in prevention measures and it went much lower down. One means here the rate of spread outside of work, at home, I guess, or wherever people went when we were told to go home. Same thing in schools. Schools were very safe places to be if you measure safety in terms of spread of this infectious disease. So this is again an example where organizations can really do some amazing things if we allow people to experiment and try these things. So thank you for your attention, and I look forward to other aspects of the supply of healthcare today. Hello.
I mean, what the general relationship between the infectious disease one and the virus club, their groups and fixed costs, what's the relationship?
Well,
Their general level.
the thing about employers, the firm in general, even if it doesn't have employees, but typically firms have employees, firm in general is there to deal with some externalities and fixed costs. That was cost, even if there were no diseases, right? So we've already assembled, we're already kind of good at it. We have a president and a provost who are kind of trained in how to do these things. And then you have a new externality to deal with. It might be a good idea to use the old institutions who've already proven it could be able to assemble a group and deal with the cheating and monitor. And the idea that we would close all those institutions who were built to solve externalities because of an externality was, I find, a ludicrous idea. That's what we did.
Different, I guess, when you have masses of people that are not, they're not internalized. So if you don't have an organization, so
Yeah.
you know, if you have a,
That's called staying home.
no, that's one aspect of it. Also, you know, if you just have people going out to, I don't know, restaurants internalize their clients and stores internalize their clients. But it's harder than it works, but you can't make as much demand.
Yep. But they're smaller organizations, and we knew that before COVID. I showed you the data. It kind of flu shot, and the small companies, you know, a lot of restaurants probably didn't have flu shot set up for their employees, right? The smaller restaurants. McDonald's probably has a flu shot program. They're a big company.
But the bottom line for you is that the larger the group, the safer, the lower the impact,
Yes,
as opposed to epidemiologists who say that.
yes. They did say the opposite.
Trust me, I know. Are we doing virtual next one?
If there's any, I mean, if there's any more questions, whether it's in the room or online, we still have like 13 minutes for you, Casey, so.
I'll ask a question on, so various states have been passing legislation to ban the rebates. Where do you think that the rebate is going to be captured? Is it going to be kept at the PBM level? So is there going to be an unintended consequences of state regulation on PBMs where they prohibit rebates back to the buyers?
Yeah, you're right, there are bills and proposals to ban rebates, and some states have engaged in that very recently. You might have gleaned from my discussion, who do you think would be in favor of banning the rebate? I mean, go to my restaurant example. Coke really doesn't like that Pepsi's offering those rebates, and Pepsi doesn't like that Coke's not offering the rebates. If they were to get together and say, let's agree with each other not to do rebates, they'd go to jail. I mean, that's a Sherman Act violation. But if they can get the government to do it, more power to them. that's what's going on. We saw that very clearly when the White House was considering, when Tom and I are in the White House, considering the, banning, rebates in Medicare. The biggest proponent was it was a former president of Eli Lilly, right? And it's not specific to healthcare. That's why, Tom and I are kind of pushing the economic analysis in general, like Onglins has IO work and he has health insurance work. I mean, the same principles apply, and we see capture of regulation, regulation used to stifle competition in all kinds of industries in healthcare.